This conference will now be recorded.
Yeah. Shall we start? It's almost 90 people, and I think people will be joining. Okay. Today's topic is common parasitic infestations in children. Actually, uh, this is not a very big topic, but the thing is, uh, it has some implication with this thing, your microbiology, and most of it we'll be discussing is about microbiology, and it helps in both your medicine and also in pediatrics. Okay. Basically it is common parasitic infestations. Okay. In how infection differs from infestation is, infections are usually caused by protozoa, bacteria, fungi, viruses, and other things, but when we say that something is infested, that means it is basically by animals. Okay. Like ticks, mites, lice, and worms, and all those things. Okay. So that is the difference between infestations and infection. Okay. So uh, yeah, now we'll be dealing about infestation, that is mostly from the worms, ticks, mites, these arthropods, not about this protozoa and other organisms. Okay. Yeah. Coming to parasites, there malaria by arthropod vector like mosquitoes, Scala azaris, leishmaniasis by sandfly, amoebiasis, though it is a protozoal, and roundworm. Roundworm is your Ascarious, spinworm, Entropius vermicularis, hookworms, tapeworms, Eugenias, filariasis by Bucraria bronchopti, and Echinococcus, that is your highlighted cyst. All these things do constitute your parasitic infestations, and we'll be dealing with a few of them in detail. Okay, because malaria and all these things are a whole class and a question by themselves. So we'll be dealing with lesser prominent things. Okay, coming to the first one, it is leishmaniasis. Obviously, it is caused by Leishmania donovani. Yeah, it is by a bite of female sandflies. Okay, and usually your leishmaniasis is of three types. It is like visceral leishmaniasis, cutaneous leishmaniasis, and mucocutaneous leishmaniasis. Okay, there are three types. Uh, Mostly in India, the cause is Donovani, as we discussed. It is, and the name Kalas are mostly these Bihar, Uttar Pradesh, Chhattisgarh. You know, those are the areas where they are more common. Okay, whenever you see a out-of-state patient with a huge spleen, you should think of leishmaniasis with a fever with a huge spleen. Okay, it is not very common in our areas. Um, so, yeah, three types: visceral leishmaniasis, cutaneous leishmaniasis, and mucocutaneous leishmaniasis. Uh, it is the pro-mastigotes which infect the macrophages, and that will cause amastigotes. Okay, and usually children of 1 to 4 years are mostly susceptible because their immunity is not so good, and uh, it is mostly by cell-mediated immunity, which is not so good, and your immune development occurs after 4 to 8 years. So your tonsils and other lymph nodal enlargement. So before that, the child is more susceptible for such infections. Okay, nothing like it doesn't happen afterwards. It is more susceptible in 1 to 4 years of a child. And this visceral leishmaniasis, as the name suggests, visceral, it manifests as a hepatosplenomegaly, fever, and weight loss. Okay, and mostly these abdominal discomfort, pallor, emaciation, cough, and diarrhea can also be symptoms. It is also called as Kala Azar because it gives hyperpigmentation, the dark pigmentation that it gives to the skin. That is why it is called Kala Azar. And there will be marked splenomegaly, as we discussed, and moderate hepatomegaly can be there. And coming to the laboratory, there will be pancytopenia. You know, pancytopenia, you must be knowing from your pathology. Pancytopenia is decrease in all cell lines. Your RBC is down, your WBC is down, your platelets are down. Okay, or by definition, or this thing, bicytopenia is two lines, pancytopenia is more than two or more than two. Okay, okay. And there will be hypergammaglobulinemia. There will be increased in immunoglobulins production, and usually there is a reversal of albumin to globulin ratio. Usually your albumin is more in case of uh, it is 3:1 almost. Albumin is more and your globulins are less, but because of hypergammaglobulinemia, your globulins will be more compared to your albumin report. That is how you can think of maybe we're dealing with the case of leishmaniasis. Okay, and microscopy will find these things. Okay, that is another diagnostic method. And coming to the management is with sodium stipogluconate. Usually it is the drug to be used, and it is given in the dose of 20 mg per kg per day. It is an injectable IM or IV for 28 days. It is up to a 1 month course. Okay, it is has to be given for 1 month. You know, these dosages and duration is also important in your exams when you're making a note of it. This is important. Okay, sodium stipogluconate, it is 20 mg per kg per day. I'm repeating so that yeah, we will remember it. And amphotericin B can be given. If it is amphotericin B, 1 mg per kg, alternate day for 28 days. Whatever it is for 28 days. Okay, there is one newer drug. This is for your entrance. Maltefosine is your newer drug for leishmaniasis. Okay, it is also duration is for 28 days, but the dosage is 2.5 mg per kg per day. Okay, this is your entrance interest actually. Okay, now coming to the another disease. See, this leishmaniasis mostly your hepatosplenomegaly, fever, can occur with diarrhea and all. If it is in our part of the country, we may have to think of malaria. But if it is from the northern side, like in Bihar, Uttar Pradesh, and Chhattisgarh areas, it is your you should think of leishmaniasis also. It is because of bite of a female sandfly. I'm repeating it so that you will remember at least one thing regarding this thing, because most of the things you must be already be aware of from your micro. I know, but this is just a brush up of your uh, remnant memory. Okay. Yeah, coming to amoebiasis. Uh, it is the common intestinal protozoal infestation. It is 10% of infected. Only 10% will manifest as a disease, and because it not like everybody who gets infected will be manifesting disease. It is caused by Entamoeba histolytica, and there will be mostly asymptomatic colonizations. You know, in the intestine there will be asymptomatic colonization. In 90% nothing happens. In only 10% somehow the organism wants to invade the mucosa and cause this bloody diarrhea. Okay, that is how your amoebiasis do present. And yeah, route of transmission is fecal-oral. You know, the cysts have been infected or the infected things, and they will develop into trophozoites, and in the small intestines they form the 8 trophozoites. This is an entrance bit again. Entamoeba histolytica will give you 8 trophozoites. Each cyst contains 8. Okay. Intestinal disease is with the dysentery. Dysentery is bloody stools. Okay. If it is diarrhea, is watery. if it is dysentery, it is bloody stools. Okay, and there can be fever, and there can be tenesmus. Tenesmus is the urgency to go for defecation, and there can be abdominal pain, and mucus and blood in stools. Okay, all these things are present, and usually for a few interesting facts regarding antamoeba is where it occurs. It is mostly in the cecum and transverse colon. Remember your cecum and transverse colon, which they're localizing the pain. Okay. And few times it will get totally invasive, and it leaves the intestine. It goes to the liver. Okay, giving rise to this liver abscess. Okay, clinical features are mostly your abdominal pain and tenderness. Usually tenderness is seen in 80% of the cases. Okay, so it is very common, and watery blood, mucus filled diarrhea, and there is your bloods will give you leukocytosis because there is an invasion of the tissue, so there will be WBC overactivity and reactivity, so there will be leukocytosis. And there are few complications with this, that is your toxic megacolon, amoebioma, there may be tumor-like thing that is pending, and cutaneous amoebiasis, and it can also cause fistulas because of this invasive nature. Okay, as it goes to the liver, it can cause liver abscess, that is amoebic liver abscess, which can be actually very rare, like only 1% or 2%. And if the liver is affected, there will be fever with chills and rigors, and hepatic right upper quadrant pain. Okay, that can be present, and there will be jaundice because the liver is affected. There can be jaundice. Okay, and sometimes there can be cough because the pleura also can be invaded. Right side pleura can be invaded from the diaphragm, and also can cause cough and distress. Okay, your diagnosis is by direct. It is by direct microscopic examination of stool samples. You know, when you do it in the office practice, you'll do it for 3 days. Okay, 3 consecutive days. Okay, then looking for any cysts that are present, and stool also contains erythrocytes because there will be invasion, so there will be bleeding, so there can be diarrhea, and leukocytes because inflammatory cells can be presented. And serologically, ELISA can be done, and immunofluorescent assay can be done. Ultrasound, and this can also give you if there is an amoebioma or a tumor-like thing or any invasion. MRI and ultrasound, and in rare conditions like isotopes can also be done to get the identification. Okay, in the blood you can see eosinophilias because there is an worm infestation. In any worm infestation, we can see this eosinophilic predominance in the peripheral smear with leukocytosis. Okay, and as the liver is getting invaded, there will be increased bilirubin, increased alkaline phosphatases, and there can be anemia because there is bleed. Okay. Coming to the management, yeah, management is in two ways. Okay, like it is anti-amoebic drugs and anti-luminal agents. Uh, why two things? These few are cysticidal, and so we give for luminal agents, and few are propozoid. That is your anti-amoebic drugs. Okay, those are your metronidazole, tinidazole, and orandazole. This is what outside practitioners they do it left, right, and center. They think that every diarrhea or dysentery is because of amoebiasis, and they give metronidazole. That is what we do. Okay. Metronidazole being the drug of choice should be given at a dose of. Do remember this: metronidazole will be given in a dose of 30 mg per kg per day. Okay, for 7 to 10 days in case of amoebiasis, because this differs from giardiasis, which we will be subsequently discussing. it is given in a dose of metronidazole in a dose of 15 mg per kg per day. In case of amoebiasis, it is the double dosage, it is 30 mg per kg per day. In case of giardiasis, metronidazole is given in a dose of 15 mg per kg per day. Okay. Yeah. Tinidazole, the ease of tinidazole is you can give it for only 3 days. The side effects and mortality are less with the dosage of 50 mg per kg per day. Okay, and luminicidal agents, this because these drugs, I mean, metronidazole, they cannot act on cysts. You need to have something that will destroy the cyst. That is your luminal agent. So that is diloxinate furoate, and this is given again the dose of 20 mg per kg per day for 10 days. Okay. This will eradicate the colonization of the gut. Okay, it will sterilize the gut and the lumen will be free of amoeba. Okay, that is the advantage of your diloxinide furoate. Okay, and combination for invasive disease for 10 days. The duration, do remember, it is for 10 days. Okay, only tinidazole, it is for 3 days. That is, you need to give for 10 days. For carrier states, you can do antiluminal like dioxanide furoate and paramomycin. Okay, paramomycin, which is not available freely in India. Okay, in case of invasive this thing like amoebic liver abscess, you may have to give metronidazole as the drug of choice again, but you may have to give it through IV in a dose of 50 mg per kg per day. It is in a higher dose, and again it is the same thing, 10 days duration. Okay, remember amoebiasis, if it is intestinal, it is 30 mg per kg per day oral for 10 days. If the liver is affected, the liver amoebiasis, that is invasive amoebiasis, extraintestinal manifestation amoebiasis, it is 50 mg per kg per day for 10 days. Okay, usually liver abscess with the metronidazole will respond dramatically, and within 3 to 4 days, all the symptoms will come down. Your abdominal pain, your hypochondrial pain, and uh, your fever, your discomfort, everything will come down. But sometimes it can last for months together, okay, to get to the abscess to be resolved. In case of severe abscess, you may consider aspiration under CT guidance. Okay, that is your amoebiasis, which is most common, and most common it presents with abdominal pain. Yeah, coming to the next infestation, it is giardiasis. Giardiasis lamblia. It is dwells in the small intestine, in the initial parts of small intestine, is your duodenum and all. Okay, sorry, and it is the common cause of your diarrhea in travelers. You go to some other new place and you get diarrhea. It is with the giardiasis. Okay, and one note with the giardiasis is the breast milk contains components, glycoproteins, and other things that can confront and fight giardiasis. Okay, breast milk can directly cause that. Okay, and usually your giardiasis is the two stages. It is either cysts or parasites. Regarding giardiasis, cysts can last for a longer period of time, like to 2 months in the surfaces and other objects. And in chlorinated water also giardiasis can stay. You know, that is the reason why you have a meal or something outside your home place. You drink water, you may have diarrhea. That is because of giardiasis, because it can survive chlorinated water, but it cannot survive boiling water up to 10 minutes. So they say that even after chlorination, it is not perfectly all right. You should boil and have the water. Okay. Yeah, the infective dosage is 10 to 100 cysts. Okay, you need to have around 100 cysts to get infected with giardiasis. Okay.
and it dwells in the duodenum because of the low pH, and that is where it gets existed, and protozoals will form, and it can cause the infection. One good thing with the giardiasis is it doesn't invade the tissue, so you don't get blood in the stools like amoebiasis. It doesn't invade the stools, but what does it do is it do present with the abdominal discomfort and distension, watery explosive stools. There is a lot of flatulence present. There is an abdominal distension, flatulence, and watery explosive stools. This is classic description. Whatever book you search is the classic description. Okay, and it will be mostly mucus, no blood, because there is no invasion. So there is no blood, luckily, and it can present with nausea and vomiting also, and it can progress to chronic diarrhea and show lactose malabsorption symptoms, because that is the most disturbing thing with giardia lamblia, because there can be failure to thrive also. Okay, macroscopic detection of the stools is the diagnostic method. The same thing, 3 fresh samples with, but in this case here are alternate days, and yeah, enzyme immunoassays and fluorescent tests can also be used. That is the modality. And one thing is, it is mostly, it can be self-limiting in 3 to 4 days. Obviously, it can come down by its own. Okay, that is what happens, right? In 1 or 2 days, we'll have diarrhea and it stop by itself without taking any medication. Okay. But in few cases, we may have to give medication, and the drug being metronidazole, same as we discussed earlier, it is in 15 mg per kg per day. In case of amoebiasis, it is 30 mg. In case of giardiasis, it is 15 mg per kg per day for 7 days. I'm repeating it again so that you remember better. Okay. If it is tinidazole, you can do it in a single dose. That is 50 mg per kg. Okay. And there is one drug like furazolidine and nitazoxanide, and these are newer drugs and which can be used in case of giardiasis, in case of large water stools, explosive flatulence, and distinction stools. Okay, you can use. Yeah, coming to the uh, worms, this round worms and all. Yeah, route of infection, all the things usually they take it, route of infection is fecal-oral, and so nothing much, your helminth infection. This is called a helminthiasis, and there are 3 groups: nematodes, cystodes, and trematodes. Your plus 1 plus 2 zoology. Okay, nematodes are roundworms. This Ascarious is being notorious, and cystodes are your tapeworms, your tenias. It's your cystode, and trematodes like flukes, that liver fluke, and other things are your trematodes. Okay, now mostly our topic of discussion is yeah, the nematodes, roundworm, and yeah, fecal-oral route, same thing. Ingested Ascariasis. Ascariasis lumbricoides, it is your roundworm, and there is few, if they gets migrated to liver, it will cause Loeffler syndrome. This is again an entrance bit. Loeffler syndrome is your hypersensitivity reaction, so you will have urticaria, sneeze, eosinophilia, and your lung infiltrates along with your cough and fever. Okay, intestinal, if there's invasion of the intestines, you'll get abdominal distension, vomiting, and discomfort and irritability. And you can see that worms being passed in stools. This is what commonly asked in the case of school children and toddlers. Okay, and diagnosis is by identifying the eggs in the
stools, or you can directly visualize worms. There'll be white worms in the stools, and yeah, treatment is albendazole in a single dosage. Sorry, yeah, in 1 to 2 years of age, you give in 200 mg single dose, and if it is more than 2 years, it is 400 mg single dose. At night we give, and albendazole once one dose, and it will sterilize the gut of your round worms and other things. Yeah, other drugs can be used. The mebendazole. Mebendazole can be given at 100 mg 2 times a day for 3 days. Or you want to give it a single dose, you can give 500 mg the single dose. Okay, that is your mebendazole. Yeah, another thing is pinworm. It is Enterobius vermicularis. Same thing, fecal-oral route transmission. It is stays in the perianal region, which itches at nights. There can be weight loss, decreased appetite and irritability, and nighttime urination. And diagnosis is again by your annual swab. And, parasitology book is a nice test, the cellophane test. You just attach the cellophane to the perianal region, and you can find the worms from the cellophane. Uh, Again, medication is albendazole, mebendazole, and pyridoxine. Okay. And another, now coming to the hookworms. Hookworms is Acarostoma deodinale. Usually, it attaches to the wall of the intestine and start sucking the blood. Okay. Uh, Around 0.15 ml of blood per worm per day will be sucked in. Nectar americanus is Nectar americanus is the new old bookworm. It is called as new old bookworm, and the clinical features are mostly it is drinking your blood, so you drop in chronic blood loss and iron deficiency anemias and proteinuria. And diagnosis is by X that you can see in these stools. And again, treatment being albendazole or mebendazole. Okay, that is regarding hookworm, Acarostoma deodinale, and Nectar americanus. Okay, and the next thing is your treatments, and before that, the treatment of hookworms. In case of Ascarious, as we discussed, we give single dose albendazole, and which is albendazole, it is better given with the fatty meal. Okay, if some examiner asks you what is the dietary advice you give, you always take a heavy fatty diet like with ghee or some biryani, and then have an albendazole. Okay, that will absorb better and act efficiently. Okay, and another this ankylostoma duodenal nectar americanus, you do albendazole is the drug of choice. And some entrance thing is your ivermectin doesn't help with your ankylostoma duodenal and nectar americanus. Okay. And coming to your pinworm, enterobius, again single dose of albendazole, but you may have to repeat it in 2 weeks. Okay, because the eggs will hatch again. All the active worms will die, but the eggs will hatch again, of course. Okay, pyrantel also can be used in a single dose in case of enterobius vermiculars. And Trichuris trichura, which is a muzzle invading hookworm. There we may have to give albendazole for 3 days, and you can think of ivermectin also. Okay, but it is very difficult because muscle invasion and worm dying in the mother is very difficult. Okay, and another thing is strongyloides. There we can give ivermectin for 2 days. That is the drug of choice. Use ivermectin for strongyloides.
and albendazole is not very effective, but you can try albendazole also. Okay, and there are two things like cutaneous larva migrans and visceral larva migrans. In case of cutaneous larva migrans, you can give single dose of ivermectin or 1 or 2 days ivermectin. That will do the job. And visceral larva migrans is something interesting. If it the worms, if it invades and affects any organ, anti-helminthics may not help you much. But what we need to do is the reaction due to these drugs, these invasion like histamines, antihistamines, and your steroids, your anti-inflammatories are the mainstay of management. Okay, that is regarding the hookworm management in a nutshell. Okay, just enumerate. There is a nice table in OP-GYN. Ascarious and ankylostoma, enterobase vermicularis structura, stronger orders and which is causing your cutaneous larva migrans and visceral larva migrans. Okay. Yeah, coming to the tapeworms, these are the uh, teniasis or that will cause cysticercosis. Mostly notorious is tinea solium and saginata. The difference being tinea solium has suckers and hooks, and hooks are not there in case of saginata. Saginata is from the beef, that is cow and buffaloes, and solium is from the pork, the pigs. Okay. Yeah, teniasis is again acquired by ineffective cooking or undercooked pork or beef, and cysticercosis is acquired by consumption of food and water, and even vegetables also do contain teniasis. Nothing like it only in people who eat pork and beef. It is also in vegetarians, you can see this. Okay, and it do present with abdominal pain and the symptomatology is basically mostly based on the site of infection. That is, maybe the brain can be affected in most of the case. That is most common, or that can largely be skeletal muscle, like giving rise to pain and fatigue, easy fatigability, and subcutaneous tissue, and spinal cord, or rarely in eyes. It can be various. Okay. Uh, why it goes to the eyes is because through blood it can lodge in the eyes also. Okay. This neurocysticercosis is again a different topic by its own, and it can present with partial or generalized seizures and raised ICP in case of multiple neurocysticercosis. Okay, this is too large in the brain. Okay. Yeah. Diagnosis is again by fecal-oral route, so eggs in the stools, and the organisms can be seen in the stools. In case of neurocysticercosis, in CT and MRI may be diagnostic, where it is a space occupying lesion in the brain tissue. Okay, coming to the management in the brain tissue, this can be around 2 mm to 2 centimeters, and with a lot of edema. Okay. Yeah, in teniasis, the drug is praziquantel in 5 to 10 mg per kg, once a dose. Okay, one dose is sufficient. Praziquantel and niclosamide also can be used. Okay, niclosamide dosage is 50 mg per kg per day. That is only once. Okay. Yeah, and in case of cysticides, like the cysts are there, if it is there in the CNS, you may have to do supportive management also, because you should start steroids first for 3 to 4 days, and only then you can give albendazole and dose of 15 mg per kg per day for 30 days, 7 to 30 days. It is not that every cysticercosis will give rise to neurocysticercosis. Even there is one cyst, single cyst staying in the brain, that can spontaneously die and clear off, but that is rare. If it is calcified and because the edema is growing, it will cause space occupying symptoms. So that is where we need to intervene and treat the condition. Okay, the neurocystic sarcosis, remember in teniasis, if it is in any other part of the body, so we give praziquantel dose of 5 to 10 mg per kg per day in a single dose. If it is in neurocystic sarcosis, so we may have to give steroids for 3 to 4 days and then albendazole 15 mg per kg per day for 30 days. Okay. In ocular and spinal neurocystic sarcosis, albendazole is not indicated because of this excessive. If the worm dies, it will result in a lot of histamine release, and that will cause more damage than the worm itself. Okay, so we are not going to do an albendazole in case of spinal or ocular. Okay, there will be loss of vision also. So we don't do ocular this thing. So the management is mostly symptomatic. We do a lot of steroids in case of ocular and spinal thing. And coming to the another condition called as your tissue nematode, and tissue nematodes are Procuraria bronchiorrhapti and Bungia malayi. Those both cause lymphatic filariasis, that is the filariasis which we will be discussing. And it is from the Culex mosquitoes. And there is another nematode, that is Dranunculus medinensis, that is the Guinea worm, that they say it can be present in case of people who attend for water needs to wells and ponds. There they can invade from the soil into the uncovered foot, and they can migrate into the body. Okay, and Dranunculus medinensis is the reason why there is the symbol of doctor comes, the staff and the snake-like thing, right? That is Dranunculus medinensis, they say. Yeah, in case of Procuraria bronchiorrhapti, the lifespan of the adult is, they do stay in the lymphatics, and the lifespan is around 10 years, and by 10 years the worm itself dies, but can last up to 40 years also. And they do present with fever, lymphangiectasis, there are a lot of swelling of the tissues, and epidermolysis or adenolymphadenitis can be present. And in case of few cases, there will be excessive reaction, that is tropical pulmonary eosinophilia. And there is easy fatigability, lymphadenopathies, and hepatosplenomegaly, and increases bronchial alveolar markings. And eosinophilia will be more than 600, that is 2000 or more. And there will be a lot of histamine release and this thing. So we can have IgE immunoglobulin elevation, and the filaria is absent in case of tropical pulmonary eosinophilia, as the name suggests, pulmonary eosinophilia. That treatment is DEC 5 actually it is 6 mg per kg per day for 10 days. Actually we give for 21 days. Few books says that 10 days, but we follow 21 days regimen of DEC 6 mg per kg per day, where we cannot find the organism. But the eosinophils will be elevated, and whether it be fever, fatigability, lymphangitis, lymphadenopathies, okay, and hepatosplenomegaly, and raised IgE levels. Okay, in those conditions we do this for 21 days of DBC. Okay, but in case of worms and all, worms can be identified by agents are staying in thick and thin smear like malaria. And if the worms are not usually visible, but you're seriously thinking of filariasis, you can give DEC provocation test. That is, give one DEC 6 mg per kg. The worms will come into the circulation, and then you take a prick from the finger and get it tested with this thin smear and thick smear. You can find the organisms. Okay. Treatment for adult moms is a single dose DEC, or you can do ivermectin also in a dose of 200 microgram per kg. Remember, ivermectin 200 micrograms per kg, single dose. Okay. Albendazole also can be given in case of these tissue nematodes in a dose of 400 mg. Yeah, that is regarding tissue nematodes. This is your radiobronchial okay. And the last thing is your echinococcus. Uh, it is called as hydatid cyst. As the name suggests, the cyst that is there, it can be lodged in liver, lung. And if it lodges in the liver, it will cause abdominal pain and palpable mass in the right hypochondrium, and then lung, if it sits in the lung, it will cause a pleural pain, that is your chest pain, and then can cause hemoptysis because of the rupture, and there can be breathlessness because your tissue, your lung is not able to expand because the cyst is sitting there. And if it lodges in the kidneys, it can cause a hematuria. And diagnosis is logical. You do an ultrasound, you do a big cyst that is seen, that is floating echogenic cyst can be present, and dot cysts around it can also be inside, it can also be seen. Okay. That is characteristic if you can see it in your ultrasound. Coming to the treatment, once there is system that is compressing or invading the tissue, you may have to excise it. And medically, you can try albendazole 400 mg. And during the resolution, there is inner membrane is separated from capsule and floats, and you can see the water lily sign. That is your ultrasound picture in case of hydatid cyst. Okay, so in a broader offset, all the medication is albendazole and stuff, and mostly single doses will be done, and all these, most of them are see this mostly is a fecal-oral route because this worm infestation and stuff. Okay, and yeah, that concludes the class. And if there are any doubts, we can deal it now. Okay, any doubts, guys? Because most of the topics is your microbiology and parasitology. You are more aware of these things than me, and this is mostly of your theoretical importance than more of practical. It is mostly a theoretical topic. Okay, people can ask a lot of questions. You can get theory questions in case of worm infestations. Yeah, any doubts? Please let me know so that we can clarify. Hello? 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 Uh, somebody can answer? Hello? Hello?
Yes, sir.
Yeah, any doubts, or can we conclude the class? If there are no doubts, we can conclude the class.
Yes, sir. Thank you, sir.
Yeah, thank you all for your patient hearing, and hope at least you guys are sensitized with the topic. Okay, thank you all. Okay, bye.